The most dangerous part of your surgery is not when the knife goes in, it's the 60 seconds of induction. The drugs go in, the jaw relaxes, the airway collapses. For a minute, nothing keeps you alive except the person at the head of the bed. You don't remember those 60 seconds. The person at the head of the bed does. Your heart rate dropped to 40. Your blood pressure collapsed. 3 drugs went in. A plastic tube went down. They kept you alive for 1 minute. Most people can name their surgeon. Most people cannot name the anesthesiologist at the head of the bed. Level 1. The medical student. 8 a.m. in a lecture hall. The Krebs cycle on the whiteboard. You will not touch an airway for 7 more years. The debt compounds every month you sit in this chair. By graduation, your loans cross $220,000. Some of your classmates graduate over $300,000 in the red. You take the bus because a car would add to the loans. By second year, you have dissected a human hand in anatomy lab. You know every muscle. You know every nerve, including the ones you will one day block with a regional anesthetic. Your cadaver was the first person who ever trusted you. They did not know your name. You don't meet your first real anesthesiologist until third-year rotations. You stand behind a blue drape in the corner of an operating room. A patient rolls in, awake, nervous, asking about the weather. 45 seconds later, the patient is unconscious and intubated. The person beside you did that 3 drugs, 1 mask, 1 tube. The surgeon has not scrubbed in for the day. You write it down in a notebook. You go home and open a textbook you will finish twice before match day. Your friends from college got promoted at their tech companies last quarter. One of them makes more than the chief of your hospital takes home in a year. You tell your parents residency pays $60,000 a year. You don't tell them it's another 8 years before anyone calls you an anesthesiologist. Something you don't know yet, of all the physicians in drug treatment programs, 11% are anesthesiologists. The specialty is only 4% of American doctors. The anesthesiologists who make $800,000 someday started in a chair exactly like yours. You close the notebook. The next lecture starts at 10. You won't touch an airway for 4 more years. Level 2, the intern. $68,000 a year. You matched into anesthesia. You do not work in anesthesia. Intern year is off service. You rotate through internal medicine, general surgery, emergency medicine, intensive care. You admit a GI bleed at 2 a.m. in the emergency department. You run a code on a patient with end-stage lung disease. You sign out at 6 a.m. and drive home with the windows down because you are afraid of falling asleep. You do not hold a mask this year. You do not place an epidural. You do not manage a single anesthetic. You are a full physician. 2 letters behind your name that let you prescribe morphine, order a chest x-ray, admit a stranger to the hospital, and the specialty you chose is still 12 months away. One afternoon on the ICU rotation, a patient's breathing tube comes loose. The ICU fellow cannot get it back in. Someone pages anesthesia over the hospital PA. 40 seconds later, an anesthesia attending walks in with a video laryngoscope. The blade goes in, the tube goes in on the first pass. The oxygen saturation climbs from 78 to 99 in under a minute. You stand in the doorway. Your hospital badge and hers are identical. You cannot do what she just did in under a minute. The patient you admitted at 2 a.m. goes home in the morning. In 18 months, that patient will come back for an elective knee replacement, and you will be the resident who places the spinal. You will not recognize them. They will not recognize you. You work 61 hours a week. You take home $48,000 after taxes. Your rent is $2,300 a month. The ABA basic exam is 18 months away. The first of 3 board exams between you and independent practice. The weekends you once had off are now full of textbooks. At the end of every shift, you sign pre-op notes for cases that belong to another resident. You write patient cleared for general anesthesia on charts for patients you will never meet in the operating room. Somewhere across the hospital, a first-year anesthesia resident is doing the job that should be yours. You are not her yet. You get home at 7 a.m. Your roommate is making coffee. You tell her it went fine. You go to bed. 12 months pass. You put on the blue cap. Level 3, the resident. $78,000. The blue cap goes on. Day 1 of your first anesthesia year, 6 a.m. You check the anesthesia machine 7 separate ways. The pre-use checkout, you draw up propofol, fentanyl, succinylcholine, and the emergency drugs you keep in reserve. Your attending stands 1 foot to your left. The first patient rolls in, a woman in her 60s, gallbladder surgery. You introduce yourself. You place the mask over her mouth. The propofol goes in, her jaw relaxes, the airway collapses, exactly like the cold open of someone else's life. You pick up the laryngoscope and put a plastic tube in a human trachea for the first time. It works. She is breathing through you now. You exhale once, your hands start shaking 5 seconds later. The 60 seconds just ended. There will be another 60 seconds in 40 minutes. Year 2. 3 a.m. epidural on a laboring mother in room 4, a stat cesarean in room 7. You have not slept in 19 hours. On the cardiac rotation, you manage cardiopulmonary bypass for the first time. For 30 minutes, the patient's heart is stopped and a machine keeps them alive. You are the one titrating the drips. You are the one calling the pressures. Year 3. You teach the new first year how to check the machine. You watch her hands shake the way yours did 24 months ago. You are studying for ABA Advanced, the second of 3 board exams. 76% of your class will pass on the first try. You sleep with the textbook on your chest. The controlled substances cart sits 3 feet from your anesthesia station every day of every rotation. You draw fentanyl up in the morning, again after lunch, again at 5. The vials stay in your locked pocket until each case ends. Something most surgical residents do not know about your specialty. 11% of physicians in drug treatment programs are anesthesiologists. For every 1,000 anesthesia residents, roughly 3 develop a substance use disorder before the end of residency. The ones who develop a propofol addiction are sometimes discovered only when their roommate finds them dead at home. You sign every vial out. You sign every vial back in. One of your co-residents misses a morning. He calls in sick. He calls in sick again on Tuesday. By Friday, he is in a treatment program in another state. You never see him again. 51% of anesthesia residents show burnout markers before the end of residency. You are in your 3rd year. You have 11 months left. September of your last year, a decision lands. Level 4, the fork. Fellowship stipend, $60,000, or first attending job, $450,000. You pick 1 door in 1 September of 1 year. 3 doors in the same hallway. Door 1 is pain medicine. You pull up the application, you close it. 48% fewer anesthesia residents applied to pain last year than the year before. The ceiling collapsed. Insurance authorization crushed the interventional procedures. And now, a general anesthesiologist earns the same $500,000 as a pain fellow's post-fellowship offer. You would spend 1 year learning a specialty that shrank during your fellowship year. Door 2 is locum tenens, no fellowship. You sign an independent contractor deal for $320 an hour. You take a 6-week rotation in a hospital in Wyoming. You work 3 weeks on, 3 weeks off. You make $400,000 your first year. You have no benefits. You have no retirement match. You have no partnership stake anywhere. Your next contract is whatever you sign next month. Door 3 is cardiac fellowship. 1 more year of training at a $60,000 stipend, $350,000 in lost attending salary, $588,000 compounded if you include the lost investment growth. You pick door 3. You start July 1st. You place a pulmonary artery catheter by the end of your first week. You learn to read a cardiac ultrasound probe sliding down the esophagus. You spend 7 months in the main operating room and 2 months doing nothing but echo studies. 3 afternoons a week, the surgeon shows you a patient's native heart failing in real time on an ultrasound screen. Every former co-resident of yours texts you pictures of their new house this year. Your friend who took the locum contract is in Portugal for 4 weeks. Your friend who took the general attending job paid off half her loans in a single year. You are standing in a fellowship operating room at 6 a.m., placing an arterial line, making less than the salary you would have earned as a general attending. The cardiac transplant patient on the table is 12 minutes from coming off bypass. Your attending stands 1 foot to your left. You recognize the geometry. It has not changed since gallbladder surgery on day 1 of year 1. 1 year. Then the drape goes up alone. Level 5. The new attending. $450,000 your first year. Employed contract. Retention bonus rolled into the number. First solo case. Total knee replacement. 64-year-old patient. You place the spinal, a fine needle, into her lower spine. The bupivacaine goes in. Her legs go warm. Her legs go heavy. Her legs go still. The drape goes up. For the first time, no attending stands 1 foot to your left. 60 seconds ago, you placed the needle. You don't know yet whether the spinal is effective. You also don't know whether anyone upstream will catch a mistake if you made one. Nobody is coming to check your work. The pager is yours. The chart is yours. The legal liability is yours. Malpractice starts at $21,000 a year, and the first premium hits your account next week. Mid-case, between blood pressure checks, you notice something. The short-term goals that fueled 12 years of your life are almost out. The ABA applied oral exam is 6 months away, the last of 3 board exams, 2 35-minute sessions in front of 2 examiners who watch you reason through a deteriorating patient in real time. 1 in 7 candidates fails at least one component. After that, there is nothing left to pass. Only this, a patient, a chart, and a pager that will go off at 3 a.m. whether you slept or not. You glance down at the name badge on your scrubs. It still says doctor in front of your last name. You still read it twice every morning. You finish the case, you extubate. The patient goes to recovery, you write the note. You walk to the break room. Nobody is there. Your former co-residents are scattered across 3 states, 7 hospitals, and 2 time zones. You eat lunch alone behind the draped door. 50% of post-pandemic attending anesthesiologists report burnout or depression. 46% feel underpaid. Even at $472,000 a year, you are 1 year in. The next case is at 1:45 p.m. By year 2, you have done 700 cases. You remember maybe 12 of them. The ones you remember are the ones that almost went wrong. The laryngospasm at emergence, the anaphylaxis on rocuronium, the blood pressure that dropped to 60/40 and needed 8 minutes of resuscitation. You go home. Your partner asks about your day. You say fine. You cannot explain what almost happened without a 20-minute lecture on induction, Sugammadex, and blood pressure. You do not give the lecture. The partners call a vote. Level 6, the partner. $622,000. The average partner distribution in a non-acquired private anesthesia group in the United States. The vote passes. You buy in. 5% of your income for 2 years goes to the partnership stake. Your fixed salary disappears. You now take a share of group profit after overhead. Malpractice, billing, administrative costs. The facility stipend, the hospital pays your group to keep the operating room staffed. The first distribution check hits your account on a Thursday. It is larger than the down payment your parents made on their house in 1986. You look at it twice. You show it to no one. 6 months later, a private equity firm makes an offer to acquire the group. Your senior partners vote yes. The deal closes on a Friday. Monday morning, you walk into work as a salaried employee of a firm in another state. Your equity was paper. The partnership track that took you 8 years to reach just converted back into a salary job with a productivity metric attached. Nearly 19% of the United States anesthesia market is private equity now, up from about 3% a decade ago. 2 of your former partners left for competitor groups within 6 months of the deal. 3 of them took early retirement. The remaining 11 of you negotiate new contracts with an administrator in another state. You cannot pronounce his last name. You still work the same operating rooms. You still medically direct 2, sometimes 3, nurse anesthetists under the care team model, billing for simultaneous medical direction while they manage the minute-by-minute conduct of each case. When the patient in room 3 desaturates at 2 a.m., you are the one who walks into the room. You are the adult in the room for 4 rooms at once. Some nights you do not see the outside of the hospital for 14 hours. The old partners, the ones who left, text you. They say the work is better somewhere else. You do not know if they are telling the truth or telling themselves. One Friday, you walk past the cardiac operating room. The lead cardiac anesthesiologist is already at the head of the bed. One of your partners did not take the private equity deal. You watch him through the door glass, still at the head of the bed. Level 7. The Cardiac Peak. $800,000, cardiac anesthesiologist partner at a high-volume academic-affiliated private practice. Most anesthesiologists never enter this room. The general partner ceiling is already behind you. But if the question is how high anesthesia can go, the answer is here, cardiac. 5:45 a.m., the donor heart is in a cooler on a jet over Kentucky 2 hours out. The recipient is already on the table. An arterial line goes into the wrist. A central line goes into the neck. A pulmonary artery catheter slides into the right side of the heart. The cardiac ultrasound probe goes down the esophagus and settles behind the left atrium. The failing heart is visible now from inside the chest. The surgeon opens the sternum. For the next 40 minutes, there is no heart in this patient. The bypass machine pumps their blood. The ventilator is paused. The lungs don't need to breathe for a missing heart. 4 monitors track what is left of the circulation. You titrate 3 drips. You hold the hemodynamics inside a window the size of a quarter. Mean arterial pressure between 65 and 75. Central venous pressure between 4 and 8. Lactate under 2. Drift outside the window and organs die. The donor heart arrives. The surgeon sews it in. You watch the new heart fibrillate, get paddled, contract. The patient's blood pressure rises on its own for the first time in 43 minutes. You come off bypass, you document it. This is your 150th cardiac case this year, your 10th transplant. The Society of Cardiovascular Anesthesiologists ran the numbers on people in this subspecialty. Between 2010 and 2020, inflation-adjusted cardiac anesthesia pay fell 10%. More cases, more training, more complexity, and less real money at the end of it. The ceiling rose in nominal dollars and fell in real value. The United States anesthesia workforce is 12,000 providers, short by 2033. You cannot retire early. Someone's heart surgery gets canceled, you cannot work less. The call schedule is built around you. You are the only cardiac attending on tonight, tomorrow night, and Sunday. You finish the case at 1 p.m. The patient goes to the cardiac intensive care unit with a new heart. You eat a granola bar in the lounge. You answer 3 pages. You start the next case at 2. 8 a.m., a lecture hall. A new medical student opens her notebook. The Krebs cycle is on the whiteboard. She has never intubated anyone. She has never stood behind a drape at 5:45 a.m. watching a heart leave a chest. She has never signed a controlled substance out of a pharmacy cart. She has never walked into room 3 at 2 a.m. because a patient is desaturating on someone else's watch. She will. 4 years from now, she will put a plastic tube in a human trachea for the first time, and she will feel the same terror you felt in year 1. 8 years from now, she will place a spinal in a knee replacement, look up, and realize the short-term goals are gone. 12 years from now, she will watch a native heart leave a chest, and she will be the only thing keeping the patient alive while the new one waits in a cooler 3 feet away. She will make $800,000. That number will be worth 90% of what it bought in 2010. Someday, she will stand at the head of the bed for someone else's 60 seconds. She will find out. Everyone does.